Verita Henderson is the perinatal practice specialist for Gwinnett Medical Center in Lawrenceville, Georgia, having broad oversight of nursing practice and nursing policy. She's also a part of the leadership team for Gwinnett Women's Pavilions. Dr. Henderson is a researcher and published author on the topic of perinatal preceptorship. Verita has worked in inner-city hospitals as a labor and delivery nurse and charge nurse. And Verita has also worked as the perinatal educator, educating parents about birth. She's worked with the East Metro Health District as a high-risk follow-up nurse and is an academic coach working to support nurses who are pursuing bachelor's, master's, and doctoral nursing degrees. So take note, Verita is your lady to go to if you need that mentoring. Verita is also A1 fetal heart monitoring instructor, a Lamaze certified childbirth educator, and an international board certified lactation consultant. Dr. Henderson is passionate about the education of perinatal nurses and the state of maternal morbidity and mortality, including the cause and, more importantly, end of racial disparities among the nation's pregnant mothers. So thank you, Verita, for joining us today, and we'll turn it over to you.
Hi, everybody. Lauren, if you all can make that bigger so that the speaker notes are not there, so that I can use those and everybody can see everything in big, because I'm going to actually, there's some slides that you'll need to have the full screen.
Sherelle,
otherwise, you'll be trying to look at it with your magnifying glass.
Yes, I am. I have it on full screen on my end. Weird.
If somebody can just weigh in and see if they see speaker notes over to the right, or
yeah, we can still see them. Charles working on seeing if she can switch. Okay, there we go.
Is that better?
Yes.
Okay, good.
Okay, thank you.
Thank you. So Lauren asked me to speak on this. Grace and Terrell asked me to speak on this, and whatever I can teach you today, hopefully, it's something that maybe you can take to your facilities, have better outcomes for your patients, or at least just see the way that we do it at Gwinnett and maybe take something from that. So I'm excited today to be able to speak with you. Slide 2, we're all familiar with it. It shows the bundle we're all working from, and of course, the last portion of that is the reporting and the systems learning piece. So that last section, reporting and systems learning, is kind of the focus of where we're going to go today. Just to recap a little bit in the next slide, we know that the current population of perinatal patients is higher acuity. At least that's what we're seeing at Gwinnett, rather than in times past. And we know that, patients with higher acuity usually need a higher level of nursing care. At GWP, we deliver about 4,500 to 5,000 babies a year, and we have a large number of perinatal patients with comorbidities. I'm pretty sure most hospitals are encountering the same phenomenon. So my role as a perinatal practice specialist is to keep up with the low-risk and the high-risk patient population. I have broad oversight with nursing policy and nursing practice. So I work closely with all the units, labor and delivery, the high-risk pregnancy unit. I work very closely with maternal-fetal medicine, the OB group, as well as the neonatal nurses and the resus team that's staffed by neonatal nurses, and then the mother-infant unit. The maternal-fetal medicine staff, providers and sonographers, kept mentioning that we kept them very busy, busier than the other hospitals that they also work at. And so that intrigued me, and I wondered why that was, and also, more importantly, how can we keep up with those patients? I noticed that the maternal-fetal medicine team was super smart at all the rare diseases of pregnancy, and so I put it on my calendar to start showing up when they rounded on the patients. So through that informal gap analysis, we found that our units needed to have even more means of following our patients, and that follow-up needed to happen before the patient ever arrived. So next slide, Anybody ever get those surprise patients? Most hospitals, I'm sure Gwinnett is not the odd, hospital. You have rare patients that show up with these rare diagnoses. There's no plan. There's no prior unhurried research into certain diagnoses. Your nurses, don't have somebody that can work through that at that moment, day or night, weekends, to help guide the care. So the staff, may be taken by surprise, not feeling sure of what they don't know. They're trying to learn on the fly. They're trying to do their best to deliver high-quality, exceptional care. And, that is the surprise thing. Most patients for us, yes, they're identified early. We create a formal plan of care so they can be treated the way that it's supposed to be. Next slide. So, we realized we needed to be more ready for all the high-risk patients if we could be. So out of this knowledge, we created a monthly meeting called High-Risk Patient Reviews. Interestingly, at one of the A1 National Conventions, I met a nurse who did a poster presentation about her role in meeting with high-risk pregnant moms, and she worked with providers to create the plan of care before they were ever admitted to the hospital, and we used that knowledge to help form the foundation for this monthly meeting that we currently have. We meet at this meeting and we discuss our maternal and our neonatal patients, the ones that are not yet admitted, the ones who are admitted at present time, and the ones who have delivered. We want to know what we did well for the delivered patients and where we may have opportunities for improvement. And mentioning A1, I hope everybody's going to be at A1 here in Atlanta. I'm excited about it, so hopefully I'll see you all there. On the next slide, I show who is at this meeting. We consider this to be truly interdisciplinary. Almost the entire maternal fetal medicine office attends, and one of their lead doctors does a very interesting PowerPoint of the ultrasounds of several patients. The nurse practitioners come, the sonographers come. Labor and delivery representation includes the manager, the educator, myself as a practice specialist to facilitate the meeting. NICU comes, their manager is in attendance, their educator is in attendance, their neonatal practice specialist comes, and sometimes we have a neonatologist that will attend. The resus team that we have here attends all of our cesareans and high-risk deliveries, so they may come to the meeting depending on what's going on that day for them. And we've also had the NICU supervisor team, so all the supervisors of the NICU groups, they may come on occasion. We have social work that comes and can speak and hear what's going on with the patients. We have a quality department representative who assembles our perinatal core measure metrics, and our director are on the calendar invite. They attend when they can. If I need them there, I can reach out to them personally to attend specific meetings. But sometimes they're not in actual attendance all the time. The next slide, I'm sure you're wondering, well, what about the OBs? They're all invited. They were personally invited. But I'll be honest, most of our OBs do not attend. We have had several meetings where they have some, different ones have come. It's a challenge trying to get every OB to come, but most of them, of course, they have, their times in the office. They may be a single group. So, they cite that time in the office as a challenge for them to get to the meeting. But the good thing is most of our OBs do refer their patients to maternal fetal medicine, who always comes to our meetings. So a great many of their patients are discussed even in the OB's absence. And this is one opportunity we have, and that is to have more of the OBs to attend when we can get them there. The next slide shows somewhat of the process. I receive a high-risk pregnant patient list 2 times a month from our hospital-employed OB group. This email has a graph of the patient's name, their age, parity, their due date, most importantly, information about their diagnoses, their recent visits, any ultrasound results from maternal-fetal medicine, and all the disciplines that may be following the patient, such as, maybe they had a cardiology consult or nephrology. I heard a...
Just want to remind everybody if they could put their phones on mute. There's a really bad echo.
Yeah.
Thank you.
Okay. So any disciplines that follow the patient, and I create our agenda for each meeting to discuss the patients that are going to be coming in within the next 6 weeks or so, based on the due dates from that list. We try to look, out into the future and say, who's going to be coming in, and we need to make sure they're on the agenda to discuss at the meeting. So I look at the due dates from the list, add the names to the agenda, and add the diagnoses to the agenda. I also search our, computer, the EMR, to see if she delivered. And if they did deliver, I research to see what happened at delivery from the nurses and provider notes. So I may add things like, what was the QBL if the patient was at risk for hemorrhage. And I add those names to a delivered patient section of the agenda. And there we have our list of patients to discuss. Usually there are quite a few, but I will say that it usually goes pretty quickly in the meeting once we start going through them. The next slide shows just some of our, relationships. It wouldn't, work without having a relationship at your hospital. And we have a wonderful relationship with our group of OB co-chairs. One is from the hospital-employed OB group, and the other is from one of the other OB groups that we have here. And they help us to kind of formalize any information about collaboration between the nurses and providers to deliver safe care. So I can take the information from this meeting that we have and even meet one-on-one to them if they're not in attendance for special things that I want to occur. Nurses are good at usually asking for what they want. So if the patient's discussed at the meeting or, their particular patient, I can ask for certain things that I want, like, can I have pharmacy makeup tranexamic acid for this patient? I believe she might benefit from that. Most of the time, they'll give me what, I want. We also have a great relationship with the maternal-fetal medicine office, so the nurse practitioners and docs will alert me to any patients to come if there are concerns. They know they can come to me or, call, and we can discuss concerns to make better nursing practice decisions for patient care. Next slide shows, kind of what we do at the meeting. We discuss the patients one at a time. We go over the the PowerPoint. We project it on the screen of the ultrasound from MFM. We go over the diagnoses for the mom and for the baby. And, we might say things like, mom has second-degree heart block. You'll see her on telemetry, and you'll see a cardiology consult. This baby has IUGR, velaminous cord insertion, fetal pyelectasis. And I kind of give the, I want to try to talk about it so I can give the nurses, they already know certain things, but some things, here's the tip, you might see this, or make sure they do that. Each member of the group talks about their role with the patient. NICU will say what they will do. Labor and delivery can say what they expect in their nursing role. We ask questions of the others' disciplines if we, don't know what their particular things about their discipline. We are pretty good at collaborating with each other. Sometimes we, don't necessarily agree, and we get to voice our concerns if we need to here as well. Some of the questions that we ask are, will resus need to attend to the delivery? Will there need to be, a need for a higher level of care? Do we feel comfortable delivering this patient at the Women's Pavilion, or do we need to deliver her at the main OR? So, the details of the care that the patient will need are discussed at that point. And then we discuss the placement of patients on the unit. For example, if our patient needs to be closer to the OR, we can put her in, we can say, we'll put her in this room that's close to the OR. Or if we need a larger room because maybe they need to accommodate resus, team equipment, ultrasound, or things like that, we can determine the placement on the unit. Some of the patients may even be inpatient at the time of the meeting, so we try to discuss orders. We try to discuss patient progress, make sure that the nursing interventions are appropriate, that type of discussion. However, there's a daily and a weekly nursing round that kind of encompasses that and looks at the quality of that for those same components: orders, progress, physical therapy needs, updates, and things like that. So the next slide, we discussed the latest NICU delivered patients. The sonographers are usually very interested in this segment of the meeting, as they usually want confirmation that their prior ultrasounds have been correct. So they are very engaged and interested in the care of those babies. So NICU is up in the spotlight at that time. They get to talk about the babies and how those babies are doing. Next slide shows sonographer roles, and they usually remember these patients by name. NICU can talk about things like whether this was a normal inpatient course, whether the baby was transported out for a procedure and came back to us, or will be staying at CHO or wherever the baby went. And then NICU can add report if additional studies were done, like an echo, a cardiology referral findings, anything that they want to report. On the next slide, we discuss quality. So we discuss prior deliveries that occurred if we need to. We don't necessarily discuss many of the deliveries because they go, pretty well, given that we've all discussed this and we create a plan there. But only those that were quite notable, and this creates that circular reporting. The patient was discussed before she delivered at a meeting. At this meeting, we may discuss her delivery, and then it gives us the opportunity to develop any education for the nurses related to nursing practice from those actual cases. Our perinatal clinician, who's our educator, will see opportunities to reinforce education with handouts, meetings with the staff, correct competencies, do drills, that sort of things based on these discussions. So we get to, discuss how other disciplines performed and contributed to the case, and our team will usually take these to the leadership of those disciplines. Examples may be the blood bank or anesthesia's role in the last hemorrhage case, and we can kind of, iron out if we need to discuss anything further with them. Some of the things in the next slide that have come out of that, based on the knowledge of some deliveries, and maybe we felt like the staff may have been unsure about a tamponade balloon. So our educator Michelle put together a competency to see how to assist the provider when it was inserted. Information about how long it should stay in, how to monitor. You monitor the blood loss with a urometer. She educated about vag packing, who could remove it, and that may be facility-based, on your hospital, who could remove it. Another big piece in talking through our deliveries is our educator found that we needed to help the nurses find their voice in prompting the provider. In essence, they tend to get tunnel vision a lot of times and lose track of time, and so, she's taught them to prompt them like, do you want Methogen 0.2 milligrams IM now, provider? And we put a laminated card in our postpartum hemorrhage medication box that includes those postpartum hemorrhage meds. It includes the dose frequency. You see here on the slide. So, that's in that box. So, if they freeze or anything, they've got that information there. It's got Pitocin, Methogen, Hemobed, you see that on there. This came from the CMQCC, and we just kind of condensed it. The nurses know the information, but we wanted to make it even simpler. This way they could prompt the provider so we could act in any emergency without delay. Our educator is also doing drills to educate about, different things based on our conversation about deliveries at the meeting. So, signs and symptoms of hypovolemia, tranexamic acid, anything that comes about with education. She took that from the meetings and, the delivery reviews and said we need to make sure that the staff knows that. So, and a good example of having a provider at the meeting is that one of them stressed the importance of, trying to, make sure we initiate massive transfusion sooner and not load the patient with more than a liter of crystalloid, and hemodilute them. So all of these little, tidbits and, collaborative workings, those came about because we discussed deliveries. The next slide shows, and this is my own just kind of, cheat sheet for me. It's not a part of the medical record, but after the meeting, I do the write-up. I have this form here. I usually will put all the information on that, and I copy it on bright colored paper. It's, I put that write-up in the prenatal file on the unit with the patient's prenatal record, and when the nurses see that page, when they pull that prenatal record, they see that bright page, they can read about the diagnosis, the nursing care that should occur, the rationale, how the units are going to work together, any reminders like make sure you get an order from the provider to start 2 IV lines upon admission, assemble the team to go to the main OR or alert cell saver to come because the patient has an accretion that's going to be delivered there. Anything that we kind of discuss or anything that, we want to be sure that we highlight, I put on this page. So I also put it, besides putting it in the prenatal record, I put it on the charge nurse clipboard, so they kind of know what's coming as well. I sometimes will do a more detailed plan of care if the disease process is odd, and on that plan of care I give a patho write-up, rationale of what the nursing is, to do, presentation of the disease, and very thorough plan. On rare occasion I have to do this type of write-up, but this too gets placed in the prenatal record and on the charge nurse clipboard. So while I'm on the labor delivery unit, putting this report sheet in the prenatal file, I'll also make copies of prenatals that we flagged at the meeting, and I take those prenatals to the NICU. They have a binder of high-risk babies to come. They arrange it by due date, and I'll speak in person to the resus nurse that's on call that day so I can give a report about the patient. So this gives us an opportunity to keep them abreast, and they use the information discussed with their resus team. The next slide, please. So when the patient comes in for triage or admission, nurses pull the prenatal record. The brightly colored write-up form is there. All the information discussed is from the sheet. Like I said, it's not a part of the medical record. It's a list of what we discussed at the meeting, a list of do not forget to do this, a list of education about the patient and her baby, and the nurse can review the documentation and add it to the front of the chart just to work from there. It gets taken out, before it goes to medical records. The next slide, just wraps up, and that's how our meeting goes. We do have some opportunities. We want to get all our OBs to give us their high-risk list. I will say that we have a few that will give it to me, and but most of them don't give us the list. And so some patients still take us by surprise, or, we just have limited time to get all of this together. Some send me an email, some stop me in the hallway or in the unit to give me a heads up. Another opportunity is, of course, you can see this will keep me very busy. Keeping up with the patients is, a lot. I will say it's a ton of work to do so, but it is very rewarding when you have all of it done and a nurse can verbalize being able to take great care of a patient because of all the prior work and research, and that's all there in the prenatal from them. And even a lot of times they'll come up and say, I learned something new. I want them to learn from their experience and know they made a positive difference in their patient's nursing care. It's great also when the providers say the team was ready, we all had a plan, we all did a great job for this patient. So that's how we kind of do our circular reporting and making sure that we report and we learn from the system. The last slide just says thank you. For the opportunity to tell you a little bit about how we report and conduct our systems learning at Gwinnett. So I'll give the meeting back to Lauren. I'll be glad to speak to any of you by phone or email or however, just reach out to me. But thank you for the opportunity to speak to you today.